to everyone in the room, everyone online. If you're joining us, fantastic for you to all come and join us to have a bit of a discussion about public health AI, so transforming health and reducing inequalities. We have a fantastic panel this afternoon to share some thinking, and I'd encourage you to join in on the conversation. I've got the Slido app here, so you can put some questions up there, vote on the questions that you want asked or answered, and I'll manage that with you as well too. So we really want to have a bit of a discussion about what are the opportunities, challenges for advancing data science and AI in the field of public health. Now, before we get into the detail and kind of pass it over to the panel members, firstly, just a bit of context. So health features really strongly, really prominently in a lot of the national AI strategies, UKRI, Transforming Our World with AI, the national AI strategy as well too, highlighting the potential for AI to both predict disease, prevent poor health, and manage health across individuals and populations. But where does public health fit in that narrative? What does public health mean in kind of a health landscape? And we all come from different disciplines, so if you forgive me a little minute, I'm just going to plant that seed in your head about what public health actually is. So public health is an art and also a science, because it's working with lots and lots of different types of people, building a case to prevent disease, prolong life, and promote health across populations. And a core component of what we do as well in public health, or everyone working in that space, is making sure that we're trying to challenge the drivers and the solutions to address health inequalities as well too. So differences in health outcomes between different groups. So that covers lots of different aspects: data, surveillance, monitoring, health, mental health, physical health, health behaviors, contextual environmental drivers of health, lots of different elements, alongside understanding what affects our health and what works to improve outcomes and improve outcomes for everybody across the population. So a hugely complex challenge. And the amount of data that's being generated across all those different aspects is just growing at a phenomenal rate as well too. So that kind of brings us to today. So what are opportunities? How can we ensure that we're applying data science and AI to the questions that really matter and are important in a public health space? So that's the kind of the task for us to talk through this afternoon. And any questions, do as I say, pop them on Slido. So if I can come to the panel, maybe Joanna, I'll come to you first because you sat beside me. From the UK HSA, and from a surveillance perspective, what do you, reflecting on where data science or AI is being used in that field of public health, and what's the potential, do you think, as well too?
Yeah, absolutely. So lovely to see you all here. So thanks for waiting for the last session, because I realised that you're probably all thinking, oh, I could get an early train, I could get out of London earlier. But it's great to have you here for this session. And this is fundamentally one of the most important topics, I think, in many of the areas of AI and data science that we talk about. A, because it hasn't overly been explored and exploited fully yet. B, because many of the capabilities and methodologies that you see across other disciplines, and I'm thinking environment, climate change, are applicable in this context too. So thinking your interdisciplinary minds, how do you use your same techniques over? And third, because I think as we go forwards, we're going to be very, very focused in our future world on the health of individuals and how we take that forwards, more than we are now. So the UK Health Security Agency has a mandate to be able to detect and respond to health threats in the UK. So it's our role to understand what's coming in and out of the country, and therefore if there's any risk to individuals. And the real challenge with this from an inequality perspective is that every threat that we see affects people in different ways, because they happen to be in a specific location, if it's a radiation threat or something like that, because they happen to be in a specific age range, because they haven't been vaccinated, because they are just genetically predisposed to that particular illness. So from our perspective, understanding inequalities, or equalities as it may be, and the population base by which the threat is going to present itself is absolutely fundamental to the work that we do. So it's fundamental in two ways. B, because we can help stop people getting ill and seriously ill, which puts a pressure on the NHS, and Albert, I'm sure, will reflect on some of those challenges. But also because it helps us to ensure that the operations that we put in place are proportionate to the threat that we're seeing in the population that's affecting. So if I may, I'll just give one example. Mm-hmm. So we saw an outbreak of polio in children in North London last year. We saw an outbreak of polio, should I say. We recognised that it was there. We started to do surveillance, and we used wastewater testing, which is a common approach for polio. We were able to pull the data up using our analytics and our international collaborations. Going back to what you were saying, public health is a team sport. There are many different people and many different disciplines involved. We were able to identify that, yes, it was in children. It was a particular strain that was spreading between 3 geographical areas, and it was affecting a very particular population in North London. So that enabled us to target both a comms campaign and a vaccination programme to that specific population. So that saved government an absolute fortune. If we'd have had to blanket vaccinate again the whole of London or the whole of England, it would have been a disproportionate response.
Fantastic. Thanks, Joanna. A really, really nice example in the health surveillance space. And you pointed or nodded there to Albert from a health system perspective. So, Albert, would you like to give your view from NHS Scotland and from a digital and data perspective?
Yeah.
So the opportunities might be.
Thanks, Alicia. Yeah, so as you say, I come at this from a digital and data perspective, and I'm always interested in analytics use cases as well as service delivery across health and care. And I guess I kind of bring an understanding of the infrastructures that we have, not just in health and care, but of the wider public sector in Scotland, having worked in government for many years across social care, education, justice, and so on. As well as actually on Scotland's AI strategy, which was the first national AI strategy of any UK nation. So there you go. Not that there's a competition.
Oh, fantastic.
And I now lead the data functions in National Services Scotland and the NHS, so with a data pillar that brings together that core capability to integrate, organise, and manage and report on data from across the health service. And I'm always very interested to understand the policy drivers that sit behind the data science and the technology and the AI that we're trying to apply in public health, and then to make sure that the contribution that we make to that and the way that we do that and the way we build our data services and our technology infrastructure is actually building the right capabilities to help answer those kind of questions and to make sure that we're driving those policy outcomes. And I guess what I see actually in Scotland certainly is a public health system that's really not poorly served for data resources. If I compare it to other public services, it's really well served. But we don't quite seem to have got it just right in terms of the infrastructure that we have to realise that potential of those resources to kind of answer the kind of challenges that we're discussing today around things like health inequalities. And there's always lots of reasons for these kind of challenges, but maybe 3 I'll point to. I think the first is around infrastructure. So just fundamentals like our ability to know what data we have across the system. In such something as large as a health economy, that's a lot of data. And perhaps our traditional approaches have been a bit overwhelmed by that and are a bit too brittle to be able to respond to change and the kind of pace that we have when we're thinking about public policy. I think the second thing is really around maybe not always having the right data, and there are gaps. And the drivers of health inequalities, as I'm sure people in this room really appreciate, are complex. And we need to look at lots of different kinds of data. And one example I would have there is data on ethnicity, which is often recorded in administrative systems, but not with the quality and consistency we would like. So we were able to bring together data from across actually a range of public services to produce a much better understanding of ethnicity across Scotland and to make sure we were serving communities appropriately. And then the third thing I think is really around risk and asking ourselves, any processing of data involves risk, and we always have to weigh up the benefits. But I think we don't always give the decision makers the tools that they need and the understanding they need of those risks, or help them to mitigate them in ways that I'm pretty sure we can when we think about things like privacy and bias. So I think there's a real challenge there for more innovative data science and AI as well. And when it works really well. So a nice example that I really like is around screening. So defining more effective screening programs and tackling the challenges associated with uptake. Often those are associated with really disadvantaged cohorts in our population. But we've been able to use data science and AI to really understand and drive up the level of engagement through carefully designed interventions and understand the drivers of non-attendance of screening programs, taking into account factors like place and infrastructure and social context as well as health. And then be able to model the impact of policy interventions before we make them so that we know that they're going to have a positive outcome, ultimately leading to better attendance and health outcomes and making sure we're serving all parts of our population. And that's a nice example, partly because it's got a really positive outcome and partly because it illustrates that we're having to draw on lots of different data, bring it together to create that complete and rich picture. So yeah, I mean, I think advanced data science clearly has a role, and my plea would be to remember that it's not only about tackling those hairy challenges, it's about really getting into and building an effective modern data infrastructure.
Fantastic. Thanks ever so much, Albert. So that's a view from the health system, and both actually from the health system, different types of health data. But another aspect is how we can draw from non-health data, so non-public sector data, if you like. And Anya, if I'd like to come to you with the work that you're doing on the digital footprint data and how that might be applied and the value of that to improving health.
Thank you, Alicia. So my background is in behavioral science. As a behavioral scientist, I was always interested in people's choices and kind of those small choices that we make every day or big choices are actually pretty consequential to our health. So for example, if I were to ask the audience how, whether you had one or two wonderful cookies during lunchtime, many people will say, yeah, I had a couple. But then if I, for example, were to ask you, did you manage not to have any cookies today? Many people might also try to say yes. So you see, the way we ask this question actually leads people's answers often. And the point I'm trying to make that, obviously it doesn't really matter how many cookies you had today, but if you get into habits of eating loads of sugar, we know it's not really good for your health. And it kind of, these small choices every day build into kind of big health outcomes. And especially it is relevant to the issue of health inequality because we know that in some communities are disproportionately affected by those kind of health choices. So traditionally, as behavioral scientists, we study those through asking people, through surveys. And of course, we know that this data is biased in many ways. People don't remember exactly how many cookies they have or how many units of alcohol they drank. They might have other biases they just don't want to tell us, or that there's sampling bias. Not everybody kind of participates in those surveys. This is kind of true across the board of health-related behaviors: exercise, diet, alcohol consumption, mental health, and so on. And the data that we have used so far, medical data, is also kind of missing a lot because, this data only records where people already have symptoms that not just they have a symptom, but they also went to the doctor, which we know is not always happens. However, there are new sources of data that we, fastly, hopefully, adopt. At least we look at them in academia. So so-called digital footprints data, so the data about your behavior, the traces of your behavior that you leave while you're interacting with digital services, that could include mobile data, how you move around, shopping data, what you buy, banking data, how you spend your money, how you distribute your money, how much you spend on gambling, for instance, if you do. So all this information about people's behavior has also biases, but it's different kind of bias. And what we're interested in is to understand how we can use this data for public health. The promise of the data is huge because if you talk about, for example, shopping data of a national supermarket, it will cover the whole of the country. And also, it will be very fine-grained because it will be, it will talk, if you link data over time, it will be individual household shopping or individual person shopping. Sort of using this data for understanding this kind of changes in population and also local areas over time can help for us, for example, to introduce interventions or to assess interventions. So, for example, if we look at pain medication like ibuprofen or aspirin over the country, we can identify areas where people buy particularly a lot of those over-the-counter medication, and then perhaps suggest to introduce pain clinics or talk to local trusts to see what's actually going on there. At the moment, these data sets are not really very much used and there are various obstacles for using these data sets for public good. However, it's changing. I think since UK GDPR was introduced, there is a shift in power of this data belonging to industry and kind of industry collecting this data. It belongs to industry. But actually, it's data about people. So in part, it belongs to people and GDPR stipulates it. So this data, we believe that this data should be used for public good. And there's loads of barriers in using this data, infrastructural barriers, methodological barriers, understanding where this data could be useful and could be not useful. And that's what we are doing in a digital footprint lab that I lead in University of Bristol.
Fantastic. Thanks ever so much, Anya. And some lovely examples there spanning all aspects of public health. So from infectious disease control and polio in a borough in London through to national screening programs in Scotland and behavioural insights. I didn't see a show of hands of who had a cookie. I did, but yeah, I'll try and be better on it. One of the questions that's come through is from James, and actually it points to a point that you made, Albert, about the infrastructure and the data in the NHS system. And how what makes it so hard to trying to bring that NHS data together into a system?
Yeah, I think just to sort of expand a little on one of my opening comments, I think the first challenge across health and social care is actually knowing what data we have. And typically what I find is we have really high quality, kind of gold standard national data sets that are really well described and brought together at scale, and we can use those. Those are a fantastic resource. But actually the data that exists across the system is far more varied and richer than that. So our ability to actually discover that data and make sure it's well described is that sort of fundamental enabling capability. I think the other key thing for me is the adoption of core standards for describing our data, things like ICD-11 and things like SNOMED. And if you haven't already, I encourage you to reach out and read the 96-page recently published Scottish Government Data Strategy for Health and Social Care, and it's addressing a lot of these core issues head on and making those commitments that are going to enable us to bring the data together in a more timely fashion to answer the kind of questions that emerge, rather than in that sort of more brittle way that perhaps we haven't had before, built around those kind of gold standard data sets, if you like.
Lovely, thanks, Albert. And Joanna, with the example you gave on the polio surveillance, that's bringing together NHS data or lab data alongside environmental data, the wastewater data that you mentioned. What if trying to understand what are some of the barriers maybe in bringing those different types of data to answer these questions?
Yeah, so much of that surveillance data is just wastewater because we don't see any cases, or we're seeing very few cases. So actually, you've only got a couple of data points coming through from NHS type colleagues. Whereas what you're trying to do is understand that community base. And that's an area for me that's just like a really big gap. What is the health of the country in any given place at any given time? And how do you bring that to the fore to understand, for those of us who do models, as your counterfactual? How do you balance the needs and the pressures of your services in a city against the underlying health that you're expecting to see? Whether that be an age demographic, whether that be an ethnicity, whether that be an understanding of the complement of disease that's in existence across that landscape at any given time. So polio in wastewater is a presence-absence test, in effect. now that we've done the genomics on it. So we are just in the case now of monitoring across the country, as is stated by our sort of obligation to World Health Organization. And hopefully we will get our status back in 12 months of being polio-free.
Lovely. Fingers crossed. And multidisciplinary groups trying to achieve that. Another challenge that you kind of have reflected on was about the gaps in the data, and that have we got the right data, and the gaps in terms of ethnicity, or it might be small area estimates and that type of thing. How do we try and improve the gaps in the data, or our understanding about the gaps, particularly if we're trying to use the data we have got to tackle something as complex as inequalities in health and health outcomes? Who would like to take that one? Anya?
Yeah, I can. I mean, obviously, I would suggest that digital footprints data could fill this gap. But the difficulty there, and we just talked about infrastructure, that the access to this data is limited. And, it would be pretty difficult to link shopping data, for instance, on national level with NHS data, because both sit in kind of separate systems. However, I think it's possible to do it in isolated studies. So, for example, we are working with longitudinal cohort studies where you can, on participants' consent, link different types of data, such as NHS data, shopping data, and other forms of digital footprint data. And then on this much smaller sample, but still substantial, several thousand people, and could be scaled up because we have a number of studies in the UK, we can look into how useful this data could be for identifying those inequalities in areas, and then think about scaling it up.
Mm-hmm. And Albert, you had a nice example there where you were joining different types of data to kind of fill in the gaps with the ethnicity data. Are there other examples where Scotland is trying to shape the way that it captures the data to?
Yeah, I mean, I think I agree. Digital footprint data, I think Anya makes a great point, is vital. I always think in the public sector we have great data about what we do to and for people, but not great data about the choices they make. And I think that's where things like, not just things like retail information, but also things like financial services information unlocks a lot of power. And whilst I recognise a lot of the challenges around that, I think there are also some causes for optimism. So you see things like the Smart Data Foundry that's starting to bring together financial services data and enable us to link that to health data in a meaningful way. And get insights into people's financial strength, and that's it's a big determinant of inequalities, health inequalities. So I think that's one angle on it. I think the other angle where we've had quite a lot of success is really around environmental and location-based data, which again place is a great way to link data together and to get insights. It also tells you a lot about the circumstances people are living in and the lives that they live, and the drivers of those health inequalities. So I think those are two examples that I would give. And I'm probably, I'm sort of on the cusp. I'm just almost allowing myself to be optimistic that we're getting there.
Can I be?
Yeah.
So I think one of the challenges in this from our perspective is that you often miss in much of the data that we have the people that you want to know the most about, and that those same groups of people are often inconsistently missed across multiple groups of data. And so the challenge then becomes, how do you know what you don't know? And how do you collect data on an individual or a group of individuals that don't engage with the systems by which the data is collected? So that's one of the areas that concerns me the most. So we've got great optimism here in bringing together multiple flows of data that are very influential and give us great insight. But of course, when we're building models, particularly looking at machine learning and different algorithms that do predictive or understanding scenarios, then what is the bias impact of not having the group in that you may be very concerned about? And often you don't know that they're not in because you don't know.
Yeah, you don't know what you don't know. What insights do the gaps give you? Is also a nice way to look at it. Aaron had asked a question which kind of leans to that about what's the risk if we get it wrong? So what's the risk for AI or advancing data science to widen health inequality? Where can we get it? What might happen? What could we prevent, I suppose, that happening? Anya?
Well, I mean, of course, if we're talking about public health, I mean, my colleagues probably can answer better, but the risks are very high. The question how to mitigate them, and I already referred to an example of working with longitudinal studies, and the benefit there, actually, to Joanna's point, that in these studies, obviously, people are selected, but hopefully nationally representative. So if, for example, some individuals not participating in certain data linkages, we can actually look at those groups and see why they're not participating, and or for example, they're missing from certain data types. We can do the analysis and correct the models. But certainly the models can't answer all questions, so we need always to be able to interpret them correctly.
And reinforce them. Another question that's come through this but it points to a point that you made, Albert, on another challenge that you threw in the mix about trust, and trust in the decision makers, and if I can add to that, maybe the public as well, and public trust. And there's a question from Hannah about what do you think might be more problematic? So clinicians not trusting AI, or public health practitioners, and that might be public health practitioners as a discipline, works in lots of different sectors, from local government through to NHS systems and others as well, voluntary sector organisations potentially. So the algorithmic aversion, so the lack of trust in an AI, or that it swings the other way, so over-reliance and kind of a sense of, oh, it must be right because of the AI. Do you have a view on that, Albert?
Yeah, I mean, I guess over the last 10 years or so, actually, not just in the NHS but in government, one of the things that has been really preoccupying me is the challenge, I guess, of getting our workforce not just bought into the potential of data science and AI, but literate about how to use data science and AI and how to interpret the outputs, because as you say, Alicia, over-reliance on these kind of outputs as truth is a risk. Equally, there's a huge risk if we don't make great use of these technologies and these opportunities. So I think there's that workforce piece, and that is around the interventions we make to help people develop the skills, to develop the confidence, the critical thinking skills, and become comfortable with interpreting that kind of information. I think naturally the other part of this for me is about public trust, and for that one of my big frustrations actually is around we need to be more confident about telling the story to the public about not just what this technology can do and these techniques can do, what it is doing for us positively today. Be confident about the positive narrative around this, and I think often we don't take the opportunity to tell that story, and the story sometimes that sits behind some of the headlines about the great breakthroughs that we see, and that has been enabled by your data and by effective and responsible and trustworthy use of your data. And I think we need to, as well as that public dialogue, I think we need to be really confident in telling that story.
Are there I'm going to press you there, Weeval. Are there examples where you think we've kind of got that right? Where we've got the public narrative about how we've used data?
I wanted to be able to cite one because there was one I heard the other day around, was it cardiac research, and it had specifically cited, again, you have to be careful about the language around these things, but it specifically cited the fact that data from, I think, Public Health Scotland had been used to inform that and the process around that. And so that was a great little example of, okay, we've got this breakthrough, this insight around cardiac research, and then here's the data that was used. So starting to develop some of that. I think I've seen it in a little bit of a small scale, but more work on my to-do list, I think it'd be fair to say.
Lovely, thanks so much. Joanna, do you have one?
Yeah, I think the best example we saw was during COVID. So, my perspective is everyone's on a journey with this, whether it be the public or individuals in different industries and government. And this sector literally has not stopped for about the past 15, 20 years. We've been through warehousing and data lakes and cloud-based platforming. We've been through every different element of restructuring and standard and management of data. We understand the importance of that, and now we're into predictive analysis, AI, machine learning. What's next? This community that produce it, I'm sure. So whilst you're on that journey, I always reflect that when I came into government 10 years ago, a lot of the challenges were about evidence-based decision making and how we got the people with the data on the table with the ministers to actually influence some of the decisions that were being made. What we saw during COVID was that being very much over the line. The data that was being briefed to the ministers was the same data that was released onto the COVID-19 dashboard, which probably all of us were looking at on a daily basis to watch that next data point come on. So there was a big movement in that time to understand exactly what was happening in the country and to use the data and the evidence that we have, albeit not perfect, to be able to represent the continuous change that we were seeing in our community. And there was an awful lot of discussion and talk from both the academic, the scientific, and the public on what that was and what that meant, and discussion about it.
And some of the lessons from that in terms of the learning, not maybe the lessons, but the kind of the learning and the application of the data science and the data to inform decision making. Do you think it's been a bit of a step change in that, and the demand for more insights, more local insights in the data to be able to inform action?
I see that in health security. I don't know what you see.
Yeah, I think certainly I've seen that also. To be able, there's an expectation now of much more rapid insights, much more that constant feed of information to allow us to make decisions much more rapidly. That has flowed through. At the same time, I'm slightly cautious about. COVID is a great example, it absolutely is, but the risk is that we make assumptions about the public license and infrastructure that sits behind that, which, in order to sustain that and do it systematically in future, actually needs continued investment in both those aspects, in that public trust and support and in the infrastructure to allow us to do that, because we achieved a huge amount, but boy, did it tell us about how much more we need to do.
And if you would just leapfrog into the future, so Johnny, you mentioned that in the past 20 years, everything's been moving at pace with all these different innovations coming down the road. If across your different areas, so surveillance or health behaviours or health systems for population health, looking further into the distance, about 20, 30 years from now, what do you think are the opportunities that we're kind of heading towards in that kind of long-term view? And maybe we go to health promotion first, or behavioural science, Anna.
I think if the data that I've been talking about is linked to other data sets like health data, we could be, because for example supermarkets data or banking data or mobile phone data goes back in time, you can actually look into people's behaviours 10, 15 years ago, if the data is recorded, when they're already starting having health outcomes. And then you can much faster, rather than having very expensive, very useful and esteemed longitudinal studies, you can do it almost immediately, because you can relate outcomes that are happening in people in their 40s and 50s and 60s to what they've been eating 10, 15 years ago. And I think it would be absolutely fantastic to have that power, but obviously devil is, as usual, in details. And even before we start applying, complicated AI models to this data, it's just getting this data together and making sense of it, what's kind of current barrier is. And I hope that it will be overcome with kind of more investment in infrastructure and research in this area.
Lovely, thanks, Anya. Albert.
Yeah, so I'd echo everything Anya says about new sources of data and bringing that complete picture into play. I guess that does present huge challenges and opportunities, and I guess maybe one opportunity I would point to in future is around actually our unprecedented ability to collaborate across sort of academic and public service boundaries, to blur those boundaries and to really come together around what are sizable challenges that we need to solve together. And I think the technology helps us to unlock a bit of that, so we can create those secure, trustworthy spaces where people can work together on those challenges, where people can share some of the recipes and approaches to doing that, and across public service boundaries as well. So breaking down those barriers between, traditional barriers between health and social care and education and so on. So that, I think, is the opportunity for us to really collaborate across and bring all those expertise to bear.
Lovely. Joanna?
So interconnected systems I like. So I like all of the digital twin work and the pieces that are coming through. But what occurs to me at the moment and pricks my conscience as a member of the public rather than a civil servant is with regard to how many times, and you guys will reflect on this as well, because I'm sure many of you are using data in different systems, we take that data and we put it somewhere else, we make a copy of it, and we store it again. And the cost of that? But all we're doing is actually re-siloing the data against other data sets that we might want to link and use it to. And then there was an article in BBC last week, that was talking about a small data centre that had been used to heat a public swimming baths that had been struggling because the cost of energy had gone up. And then you start thinking, there's got to be a better way. Instead of moving the big data sets, and you're duplicating them in effect, we've got to be able to rationalise the data that's useful that we need, and we've got to develop different technological solutions to be able to bring that data together for particular insights and analytics that we want to do. And then, from the digital twin perspective, how do we use the outputs or the residual heat or energy that's brought from these data centres to actually, heat houses, heat swimming pools, benefit back to society, because these, of course, are all costs on the public purse as well.
Yeah. You meant both of you, well, all of you using the word "we need to do this," "we need to do this." Whenever you say "we," who do you mean? Who's in that space of to be able to, further refine and develop the infrastructure, to be building the capability and the capacity within the workforce and the public health and data science and analytics. But what's the role of some of the others that might be involved, like academia in that space, or might be industry, particularly from the health behaviours perspective as well too? How do we bring all of who's in the we, and how do we bring them together better? Joanna, I'll go this way round.
Yep. So yes, I partner with lots of different academic groups for this. So all my hardest questions go back to academia, and probably the ones that are completely impossible to answer. But also what it does is stimulate a lot of different ideas and a lot of different work that comes through and leads on to different areas of work, whether that's in our area or elsewhere. So a big advocate of working in collaboration with different groups and indeed industry and the third sector as well. One of the real benefits, I think, is the interdisciplinary nature of how we work and what we work on. And even since sort of my PhD days, one of my top tips, anyone who's going through that horrible stage at the moment, is to look across different sectors as to what they're doing and pinch their methods and apply it into your sector. Because there is so much that's thought about and developed in one sector that is then never passed on to different areas. And collectively, we have to be better, I think, at understanding what best practice looks like and how we then make that continuous improvement.
Mm-hmm. Anya?
Yeah, I completely agree with what Jana said, that bringing people together. And in my field, it's multidisciplinary and multi-sector, because different disciplines in academia, they use different methods and, for different goals. So epidemiology would do it for health, but, behavioral science would do it to test behavioral theories. Economists will do it for, to achieve to test economic theories. And sometimes it's really hard to bring all these people on the same page. And then there is industry who kind of holds the data, who have completely different set of incentives and different even turnaround of staff, which is kind of an issue. Because before we in academia get the funding that we've been applying for like 3 years through several rounds of failures, people in the company that given you support letters already changed, and you need to sell this idea again. And it's a constant barrier because nothing ever aligns in time. And of course, then there is policymakers who also work on different set of incentives and timescales and missions. And I think bringing this together is really, really challenging. But I think if it does come together under some umbrella, that could be very, very fruitful, because we're all kind of, even though the incentives are different, often trying to push the same agenda. And yeah, I think we should work together more.
Thanks, Anya. Albert, would you say the same, or?
I'm hardly going to say no. And I did say, earlier, I'm a big fan of permeability across organisational boundaries and so on. I think we're building the infrastructures that enable that. And I really need academia, industry, and my colleagues across the public sector to respond, to help me build the technology infrastructure. I loved your point, Johanna, about creating data services that allow people to consume data rather than shifting it around. God knows we could do with some more heated swimming pools, though, so I don't know, minuses. And and enabling that collaboration that Anya so eloquently talked about as well. So definitely gets a big thumbs up.
Fantastic. We've got a quick question from James in the audience, which is, we've reflected on the challenges and the infrastructure and the trust and capability and capacity. But if a question to the panelists, could you name one specific, ambitious and achievable, which I think is the biggest challenge actually, data science goal that you'd like to focus on in the next, 2028, so what's that, 5 years? A minute to think.
Did you say 5 years?
5 years, 2028. Thank you, James, wherever James is. One specific, ambitious and achievable.
So my top one at the moment, with regard to pandemic preparedness, is how do you detect threats fast? And threats could be anything. So from across animals, plants, humans, we can see things coming in. We've also got a very permeable border in the UK. We cross that border regularly as a population. So the interconnectivity of the world is a thing for us as well. And so how do you maintain a good surveillance network that enables you to identify something that comes in? It might be man-made. It might be an evolution of something that we know. It might be a random strain that hits the population badly. But how do we know? How do you build the algorithms that enable us to ensure that we've got the right detection mechanism? Bearing in mind that many of the threats that we see are always at a baseline in society. So we can't do presence-absence. It's much more sensitive, much more nuanced.
A good challenge, if you're interested. We're looking for multidisciplinary teams. Anya or James, have you got one in your head?
Well, I will go back to the longitudinal study. So I work with longitudinal linkage collaboration, which is a effort to bring multiple longitudinal UK studies together in one trusted research environment to link various data sets. And I think achievable but very ambitious goal would be to build in digital footprints data in their pipeline. So I know that they now have about 20 studies already signed up. So, if everybody kind of can sense that that's 500,000 people. So if we can create a system where we can link data on such a scale, to the studies which have detailed histories of people's behaviors, medical records, and so on, I think we can, form a lot of interesting data science questions.
Fantastic, thanks, Anya. And Albert?
Yeah, tricky. How specific do we want to be? I guess if I think about what sort of preoccupies ministers just now, a lot of it is around pressures on the system. So maybe if I think about that and something that might try and help us help them around that. but also help me with our goal of kind of long-term investment in infrastructures for data. What I'd really like to see is whole system modelling that allows us to anticipate those pressures using real-time data from across the health system and then model the impact of policy interventions around the allocation of resources to address those pressures. And if we fix that, we'll get better decision making, and I'll get my real-time data infrastructure as well into the bargain. So, nice one.
Fantastic. That's a wonderful way to kind of bring this session to a close, I think, with setting out some challenges that, according to this panel, are specific and achievable in 5 years. So in 2028, AI UK will come back and see how far we've got, maybe with those three, which would be fantastic. To bring this to a close, we've spanned, hopefully you've had an induction into public health, if that's not the area that you're in. We've spanned health surveillance and the surveillance of threats and health itself, health and care systems, the NHS data, and also the importance of our behaviours, because we're all humans and we operate differently in these different systems and different contexts. So just to bring it to a close, if you could just join me in thanking Joanna, Anya and Albert for joining me this afternoon.